then it looks like you're like dialing in from your like house in the Hamptons or something. It's like very sunny and very clean looking in the background. Keep waiting for a Kardashian to walk by or something. Like it's looking pretty fishy back there. All right, 12:16 it is. So we are going to roll. Still a little thin, but I'm sure people will filter in. It's a sunny day, and God only knows we need more of those in our life. So I'm sure people are hopefully enjoying that. So first things first, we want to take the opportunity for the network, for those who haven't gotten the chance to meet Bob Adams. So the quickest explanation is Bob Adams is the new and improved Erica, is our director of pharmacy. And so Bob has joined us in this last week, and so you'll be seeing a lot more of his face. So I'll turn over to Bob to say hi.
Hi, thanks. I don't know if I'd say improved. That's a big stretch. There's some big shoes to fill. Getting all the information and all the feedback that I've gotten so far, Erica's done a wonderful job setting me up and really representing pharmacy, and I hope to be able to continue doing that for her.
Perfect. Thank you, Bob. Lucky to have you. Bob's been great. He's going to be a huge addition for us. So look forward to working with him and then have him work with you guys as well. So all good news. So I will jump in. Actually, so a few updates that folks may have seen, but as always, data kind of filters in from various sources. So wanted to touch on a couple of things. First and foremost, the children's vaccine. So the FDA panel, remember they go through a series of different subgroups before it gets final review. Moderna has submitted their 6 and under vaccine, so it's a little bit different now. Pfizer has a 5 and under, Moderna 6 and under. Moderna has submitted their data for review. Moderna has and I always get this wrong, a 2-dose series at 1/4 the dose of the adult vaccine. Pfizer has a 3-dose series at 1/10 the dose of the adult vaccine. The FDA, Califf, and others have basically said they're going to hold their first meeting on June 8th. The Moderna vaccine data will be reviewed at that meeting. It is unlikely Pfizer will have submitted their data by that time. So Pfizer's data may not get reviewed until July. There was some discussion that they were actually going to hold that initial approval meeting until both entities had submitted their data. But Califf was quoted as saying they were going to move forward with the June 8th hearing as scheduled. So that may create a dysynchrony where Moderna actually becomes available before Pfizer, but who knows? It all depends on what the review looks like. So again, Moderna had initially started as a 2-dose series for the children. They've gone to a 3-dose after the 2-dose series did not show great potency, but as a 1/10 the adult dose per 3-dose series. And Moderna is a 1/4 dose of the adult vaccine in a 2-dosing series. So there will be an extra dose added for the Pfizer vaccine for the 5 and under group. And just to make it as complicated as possible, Moderna will be approved for 6 and under, Pfizer for 5 and under. So that'll just make it an extra little bit of excitement for the what do we do if you're 5 or 6 kind of game plan. So there's that piece. The other piece that has come under quite a bit of discussion is Paxlovid and relapse of COVID after initiation of Paxlovid therapy. So this is called on in the popular press that there's been a significant outbreak of folks who have COVID, treated successfully with Paxlovid. They see a decrease in symptoms and even in some cases, complete return to baseline. And then at the conclusion of the Paxlovid series, they have a relapse of their initial COVID symptoms. And it seems that the course didn't last just as long in some cases. So a couple things. The relapse is real. However, it has currently only been documented in slightly more than 1 in 3,000 patients that receive Paxlovid. That 1 in 3,000 actually is much more likely to be significantly immunosuppressed individuals. And that is the group who we have known have had a more protracted course of COVID because they have less ability to fight and clear the virus as quickly. So it does appear that that group still gets the benefit. It is unclear as to whether they get an equal severity in the relapse, but it is only 1 in 3,000 individuals. So it is still extraordinarily rare. It's actually slightly more than 1 in 3,000. So while it is getting a lot of discussion, and that group probably is the group that gets the most benefit from Paxlovid, I do not think there would be any reason to dissuade people from getting Paxlovid at this point, in that it would give them a more protracted course. It is a potential, but it is a very small potential, and it is not clear that it causes a longer course of disease. It is just a temporary reprieve. As to whether there will be an extended course of Paxlovid in those individuals to maybe minimize the symptoms, but give them the longer clearance time that they may need for their immune system to kick in, there is no discussion of that at this moment that I have seen. So right now, it is a risk. There is no, that I'm aware of, there's no absolute provision. However, there is certainly no indication about a second course of Paxlovid. And I'm not aware of any effort to try to get an extended treatment course for immunosuppressed individuals who will receive Paxlovid. So just know that is out there. The other piece that is currently going around right now is that right at this moment, 60% is the estimate of people who are being infected with COVID from either pre-symptomatic or asymptomatic individuals. So whereas before, we knew that there was this kind of asymptomatic period, that there was a proportion of patients who would be COVID positive but would never mount symptoms, because of the relative lack of severity with the newer subvariants of Omicron, it does appear that there is a higher preponderance, about 30 to highest I've seen estimated as 44% of patients who get the newer subvariants of Omicron who are completely asymptomatic throughout their course. And 60% of people who are getting infected are being traced back to asymptomatic or pre-symptomatic individuals. So all of that is to say, for all of the protective measures, such as masking, social distancing, whatever, there is probably a better argument at the moment for maintenance of those measures in the short term, especially in crowded, congested locations like, not that we have this in Rochester, but subways, small venue conglomeration, that kind of thing. That masking is probably more valuable because the incidence of transmission from asymptomatic individuals is higher now than probably ever before. So I put that out there just because more and more, and I will even say I'm a victim of this myself from sometimes. If I leave the mask in the car and I'm heading into Wegmans, I don't necessarily run back to the car to grab my mask the way I did 12 months ago. But probably you could make an argument that now more than ever before, the mask has just as much value because you're not as likely to catch it from the person who's coughing and hacking and sneezing. You're more likely to catch it from the person who looks just like you and me, who's completely asymptomatic. So I do think that's probably important as folks ask, can I get rid of this mask? What the hell is the purpose of it? You may be able to argue that now the mask is more valuable than ever before. The other factor or statistic that I find somewhat interesting, I think this was the CDC that put this out. If you compare folks who were vaccine resistant a year ago to the proportion of vaccine resistant individuals today, it has almost not changed at all. So those folks who 1 year ago said, no way in hell am I getting vaccinated, were absolutely being honest with us when they said that. There is nothing that has changed their plan in the course of the last year. So we are not seeing a movement of that group of individuals to getting vaccinated. And so I think what we are seeing is that there is a significant proportion of that group who has been exposed, who have become infected, and who have developed exposure-related immunity because of it. And the estimate right now is that probably north of 60 to 70% of the US population either has some degree of protection because of COVID exposure and illness and or vaccination. So I think the likelihood that we are going to see some major uptake of vaccination in those who have not been vaccinated to date, sans the younger children, I think is very unlikely. There's nothing that's happened that has moved them in the last year. There is no mention of any new vaccines that are coming other than potentially a yearly conglomerate vaccine that will be given every fall, much like a flu vaccine. But I think the likelihood that we're going to see our friends and neighbors who were not willing to get vaccinated last year suddenly be willing to get vaccinated this fall is probably not going to happen based on what we've seen so far. The next piece is that once a year vaccine that has been discussed, rumored, potentially coming. That does seem to be picking up traction, although to my knowledge, neither of the two big mRNA vaccines, which is likely who it will be, Pfizer and Moderna, neither have a multivariant vaccine that has been trialed yet that I'm aware of. So whether that will come in the fall, there's a lot of discussion about it. Remember, it only takes about 6 weeks for them to generate a vaccine now with that mRNA technology, and they would not have to go through some grander approval process because it would just be the experience of that particular conglomerate. I think they are intentionally pushing it because they're waiting to see if there are other subvariant strains that become more prominent through the course of the summer. So, will we see that once a year multivariant or multivariant dosed vaccine coming available later this year? Very possibly, but nothing as of yet. The other piece that is probably important for folks to know if they haven't seen already is the FDA did come out and put what I may say is the oddest warning or limitation on the J&J vaccine. So basically they are advising against use of the J&J vaccine, except and limited to those who are 18 and older who do not have ready access to either of the mRNA vaccines because of the risk of TTS or thrombotic thrombocytopenia syndrome. So I take that to say, I am not aware of any area of the country, certainly in our region, that has a preponderance of J&J vaccine, but a paucity of Pfizer and Moderna. The only other slight stipulation that they added in their restriction was that if a person would not take any other vaccine other than J&J, then it should be used in that case. So it's a weird limitation. It's if you don't have Moderna or Pfizer and you will refuse to get anything other than J&J, then use it, but otherwise don't use it. And they've explicitly said it's only limited to 18 and over. So I do not foresee the J&J becoming a player in the pediatric space. So it was a weird black box kind of discussion, but what that does for any of us, I'm really not quite sure. And quite honestly, I find that it's pretty damn hard to come across J&J vaccine these days, even if somebody does want it. So I'm not sure when that would be the last option, that's the only one we've got on the table, but maybe somewhere in the far outreaches of the country that is true. So I put that out there. It's just an interesting note, but I don't know that significantly affects what any of us have been doing. I think most folks who are vaccinating are using Moderna and Pfizer, and J&J is kind of a offshoot that you're going to have to go searching for if you so choose to do so. The final piece, there are two, the Skip Pack and Acculara home antigen tests for COVID that has been withdrawn from the market. So the Skip Pack was actually withdrawn because of high rates of false positivity. The Acculara antigen test was withdrawn because of some manufacturing contaminant that was leading to intermittent false positives. To my knowledge, I have not seen either of those two in circulation in any of the pharmacies. They've not been distributed by the school systems or the county. So I don't think those are big players in our community that I'm aware of. But just know if antigen testing is something that you are distributing from within your own office, or if folks do ask, it is Skip Pack, which is actually one word, just like it sounds. Take those two words and cram them together, or Acculara. Those are the two antigen tests that have been withdrawn and are being advised not to be used if they have been purchased or in circulation otherwise. Otherwise, I've not heard any other updates or advisories about testing. I will say that the amount of COVID testing has really plummeted. even though the incidence of COVID positivity has gone up. When we look at hospitals, if you go back about 6 to 8 weeks ago, we were seeing a pretty significant decline in hospitalization for COVID. We are now seeing an increase. I will tell you, a week ago, I can speak from noise. We had, if you go back 6 weeks ago, we had 1 to 2 patients a day who were COVID positive. 5 days ago, we had 10 or 11. However, more and more it is patients who are getting admitted who are found to have COVID on screening testing. They are not coming in for primary COVID symptoms. And there's I think there's only 19 patients in the ICU across the entire Finger Lakes region at all the hospitals who are in an ICU for COVID. And of those, I think it is only about 25% who are on a ventilator at this point. So it is still pretty unlikely that you will get admitted for COVID. It is very unlikely that you'll be admitted to an ICU for COVID. And it is extraordinarily rare to go on a ventilator for COVID at this moment. Whether that is because of a decrease in virulence of the current Omicron strain, whether that is because of a preponderance of antibodies due to prior exposure or vaccination, whether that is just meanness, I'm not sure. But right now, COVID is a thing, but it is not causing widespread hospitalization, which is good. The final piece, and again, this depends on which news outlet you read, but I'm going by CDC data. As of this morning, we are 263 COVID deaths away from topping the 1 million COVID deaths in the US since the beginning of the pandemic. Yesterday we had 275, so the data would hold true that by tomorrow morning, we will have officially reached 1 million deaths from COVID in the United States, which is not the greatest benchmark to reach, but just gives you a scale of how significant this has been over the last couple of years. So with that, I am now going to shut up, which always I say that about 12:32. Today is 12:33, and I will hand it over to Elton.
You're very predictable. Excellent. So I really only have one thing. It's a follow-up from a question that came up last week, or not last week, sorry, 2 weeks ago on our call. And it has to do with recommendations for Paxlovid use for kids who are 12 years of age and older. So there really has not been anything formally put out from the Gossamer Children's Hospital or the PEDS ID team. And the guidance from the American Academy of Pediatrics, et cetera, is all a little bit vague as well. But what the PEDS ID team is doing that they shared in terms of practice is they really are recommending this instead of monoclonal antibody therapy for those over 12 years of age, over 40 kilograms of weight with immunocompromise, for whom immunization may not have been sufficient, sort of your tier 1 group, but also would certainly consider and do as well for adolescents at risk. So those with severe obesity or significant asthma or chronic lung, kidney, and heart disease. Again, it has to be over the age of 12, over 40 kilograms of weight. The caveat that they called out, which I'm sure our teams are aware of, but you have to have an estimated GFR over 30. There are dosing adjustments. I'm sorry, less than 30. There are dosing adjustments for 30 to 60. And so there's a lot of caveats in there. So we're going to try to do working with some of the pediatric pharmacy team. And Bob, I'm looking at you right now because I think with our pharmacy team, we could pull together a little clinical pearl that we can at least share those pieces of information, because I know for our peds and family medicine providers caring for kids, there's a lot of questions coming from parents about use of this because they know it's more readily available. It's being used more liberally, I think, in adults. So we will pull something together, but those were the caveats that were given from PEDS ID at this point in time. And the other thing I would just say is there is nothing else that's new in the school space. It is all the same as 2 weeks ago. I think we are limping across to the finish line, to the end of school. All of you know there are plenty of kids still testing positive. All of us are getting those of us who have kids in the schools are getting the little reports your child as, you know, has a student or a teacher or a coach or a whole team that has tested positive around them, you know, think about wearing a mask. And so I laugh about this now because I think we just have to keep doing the best that we can do in this space. And fortunately, as Chaz put forward, we're not seeing a huge increase of kids in the hospital. At the Children's Hospital with COVID, there was a slight bump over what they'd been seeing last month. But again, no patients in the ICU. There had been one case of MISC that was in a patient who was not vaccinated, but that's an N of 1. So we still do believe that vaccination does help to prevent more severe disease. And then we'll be just waiting for early June and see if we can start vaccinating those little kids for those families that are willing to have them be vaccinated. So if anyone out there is having any we'll be having another meeting with you all before that time, before that approval. But if anyone is having any struggles with getting yourselves ready to do that vaccination or haven't stood up the ongoing vaccination abilities, please let us know. We're happy to consult and help you on that. So back to you, Chad and Renee.
Perfect. Renee, anything you have for the closing arguments?
Nope, I'm all set. If you want to give us an update on our meeting cadence issue, that'd be great.
Yep. So apropos to the discussion at our last meeting and with some feedback from different folks, we are going to change our cadence to once a month now. Several things. Number one, it is clear that there is still some informational value and some, I'll say, organization that potentially we can provide to this information. Even though it is not coming as fast and furiously as it was a couple months ago. Additionally, you know, we are aware that there is some value that bringing information from the hospital operational side that for those, especially in our private practice world, don't have as ready access to, that we can provide that, and then also relay information for issues that you guys are experiencing, either getting patients in or getting access to certain specialties or whatever the case may be, that we can take back. So we continue to want to do that. The other thing is, like we said before, we've kind of built this kind of community of sharing and information that has become extraordinarily valuable. And I feel like it would be a waste to lose what we have built as far as distraction. But we do want to also have the ability to repurpose this so that there may be some other operational things that are outside of COVID. I think, as we talked about before, we are entering that phase where we are practicing under the effects of what COVID has done to the delivery of medicine, but it may not be necessarily directly about what COVID is doing right now or about the virus itself, but it's still important. And so making sure that we can kind of share best practices, talk about what needs there are, and try to be responsive to that, I still think has value. Finally, we want this to be kind of an open forum. So if there are issues that you guys have or needs that you're identifying or things that you're feeling are not being met otherwise, whether by us or whether in the community in general, I think this will be a good forum to bring that back. And if it's not something we can resolve here, then the team can take it back and see what we can find or what resources we can mobilize to try to address that. So I think there's still value, you know, whether this is something we'll do for the rest of our days and LJ, Renee, and I will be showing up in a cane or our wheelchairs in the nursing home. I would hope not, but I'm not opposed. But I do think there's still a lot of information sharing that can happen between here and the nursing home. So we'll find that dividing line. But for now, we will do that monthly. And so we will plan to see everyone back here in 30 days, unless the world crashes and Ebola suddenly starts to spread, in which case we will reach out and reconvene. And then we'll have fun with that. So any concerns, issues, thoughts, problems, withdrawal symptoms that people are experiencing that they would like to share?
I would just add that our schedule will be every second Wednesday of the month. So our next call will be on June 8th.
Perfect. There you go. And I will probably need at least 65 reminders, because the second Wednesday, that just doesn't work in my head for some reason. So I will, if I don't show up, I'm not just gonna say, I'll just probably be sitting somewhere, just playfully eating a peanut butter and jelly sandwich. So feel free to, but I'll make sure I'm here.
We'll remind
Nice
you.
try, boss. It's on your calendar.
That nursing home is not that far away, is what I'm trying to do.
Whoa, boy.
All right. Well, it's 12:40. If there's nothing else, we'll give everybody the rest of their lunch hour back and we'll see you back next month. Yes, we will send the link out.
Yes, the week of the meeting. Yes, we'll do that. Thanks, everybody.
Take care.
Take care.